All right, so STEMI, criteria for STEMI, new ST elevation greater than or equal to 1 millimeter in at least 2 contiguous leads, or greater than 2 millimeter in men, or greater than 1.5 millimeter in women in V2, V3. So it has to be 2 in men, 1.5 in women in V2 and in V3 to meet criteria. The other criteria, so that's one of them. If one of those criteria are met, it's meets criteria for STEMI. The second one being new ST depression in at least 2 leads in V1 to V4, and another one, third one, multi-lead ST depression with ST elevation in AVR, and then a new left bundle branch block with acute symptoms. So if one or more of these criteria are met, meets criteria for STEMI, and of course with typical chest pain as well. So you of course do not have to wait for high sensitivity troponin to make that diagnosis. Clinical evaluation and risk factors in patients. Always consider a patient's baseline coronary artery disease risk and their underlying risk factors. Review prior stress and cath data. Of course, there's increased risk of MI with underlying, infectious causes, especially influenza. And it's always important to treat secondary causes of myocardial demand that may be occurring in the patient simultaneously. So that's for STEMI, diagnosis of NSTEMI. As I said in previous podcast, 2 out of 3 criteria have to be met: typical chest pain with ECG changes or cardiac biomarkers. So it doesn't have to be all 3. And you can technically also make diagnosis of NSTEMI with no chest pain, only ECG changes and troponin elevation greater than 99 percentile and delta change. Diagnosis of unstable angina still falls under the category of acute coronary syndrome, ECG, and typical chest pain with negative biomarkers. Okay. Next up, we'll be talking about basics of revascularization and timing onset, as well as CABG and fibrinolytic agents.